Hey folks, Chris Sosha, the Gen X pharmacist here. When I was growing up in the 80s and 90s, pharmacy and pharmacists were the number one trusted profession. Somewhere over the last 30 years, we lost that mantle, and I think that's wrong, and I think we deserve to have that title back. This is the first episode of the RX Reflections podcast, and I have so much to say that I'm actually breaking it down into two episodes. The first explores why we are no longer number one, whether it's due to opioids or external factors the public and patients don't see, and the second part will deal with what the results of those external forces have been, including pharmacist depression and, unfortunately, pharmacist suicide. Like so many of my pharmacy brethren, I love this profession, and I want to save it for future pharmacists and show the public, show PBMs, show legislators, show state boards and medical societies why we are not only the most accessible healthcare profession, but why we should be, once again, the most trusted healthcare profession. Welcome to RX Reflections. There's a number that stopped me when I first came across it, 645,000. That's the number of Americans who died from opioid overdoses between 1999 and 2021. More than the entire population of Baltimore, gone in 22 years. And here's the thing that keeps me up at night about that number. It didn't happen because of criminals operating in the shadows. It happened, in large part, inside the legitimate American healthcare system. It happened because of a marketing campaign, because of corrupted science, because of accreditation standards that were quietly sponsored by the company selling that drug. Because doctors, nurses, and pharmacists were taught in school, in textbooks, in continuing education seminars, that their fears about opioid addiction were irrational. Pharmacists were told that they were the problem if they hesitated in filling certain prescriptions. And when the crisis finally crested, when the overdoses started making front pages, when Congress held hearings and states filed lawsuits, the people left standing at the counter, absorbing the public's fury about drug prices, about medicine access, and a broken system they didn't build, were the pharmacists. This is a story about a profession, about what it's owed, about what it lost, and what it costs the people inside when a system fails, but keeps asking them to hold it together anyway. Over the next two episodes, I'm going to go deep into the American world of pharmacy, the profession most Americans interact with more than any other in healthcare, and the one that the public probably understands the least. Today, in episode 1, The Trust That Broke, we're going to talk about how pharmacists were once the most trusted professionals in America, how that trust eroded, and how one of the greatest public health disasters in modern history, the opioid crisis. Let's start at the beginning. For most of the 1980s and into the early 2000s, Gallup asked Americans the same question every year. Which profession do you trust the most for honesty and ethical standards? Year after year, the answer was pharmacists. Not nurses, not doctors, not clergy or military officers. Pharmacists. It wasn't an accident. It reflected something real about how the profession worked and what it meant to people. Think about what pharmacy looked like back then. Most communities had a local pharmacy. You probably knew the pharmacist's name. They certainly knew yours. They remembered that you couldn't take certain medications. They noticed when something seemed off, when a prescription seemed too high a dose, or when a patient came back too soon for a refill. They were, in the truest sense, a neighbor who happened to know a lot about medicine. And crucially, they were accessible in a way no other healthcare professional was. No appointment was needed, no referral, no 6-week wait. Walk in, ask a question, get an answer, completely free. That accessibility built genuine relationships, and genuine relationships build trust. This is the system I knew when I entered pharmacy school back in 1993. Then things started to change. The first shift was structural. Over the 1990s and into the 2000s, independent pharmacies, the ones owned by people who worked in them, who knew their patients, who lived in the community and the neighborhood, began losing ground to large chain operations. The economics of pharmacy were changing. Drug pricing was becoming more complex. Insurance companies were exerting more control over reimbursement. And then came a force that most Americans have never heard of, despite the fact that it touches nearly every prescription they fill today. Pharmacy benefit managers, PBMs. Even today in 2026, most of the public have no idea what a PBM is or what they do. PBMs are companies that sit between you and your insurance plan and the pharmacy that fills your prescriptions. They negotiate drug prices with manufacturers, create the formularies, the lists of covered drugs, and decide how much pharmacies get paid for each prescription they fill. On paper, the idea makes some sense. Consolidated negotiating power, driving down prices. That's the pitch. That's the pitch they give employers and insurers. It's the pitch they give state Medicaids and the federal government for Medicare Part D. The reality is a bit more complicated. Here's what the numbers actually look like. Pharmacies are reimbursed below their actual cost on approximately 20% of the prescriptions they fill. And when I say below cost, I'm talking ridiculously below cost. In my pharmacy, $20 below cost is a common occurrence on a brand name medication. But I've seen many times, like more times than I can even count, reimbursements $300 to $400 below cost. On another 15% of prescriptions, reimbursement is at cost or just below. On another 20%, the total reimbursement is $4 or less. And it costs somewhere between $10 and $15 just in overhead to process a single prescription. Many states actually put that number at $10.92 per prescription to pay the pharmacist, the technician, the software systems, the liability insurance, the utilities, the rent. One independent pharmacy owner put it this way, and I think it's pretty valid. You can sell a candy bar for $3 and make more money on that candy bar than you do selling a prescription for the same price. And you don't have to pay a pharmacist salary to sell the candy bar. The top three PBMs, CVS Caremark, Express Scripts, and Optum Rx, control about 80% of a market worth nearly $600 billion as of 2024. And all three are vertically integrated, meaning they also own pharmacies. They're simultaneously setting our reimbursement rates and competing with the pharmacies they're reimbursing. There's no other industry where this occurs. PBMs pay their own pharmacies more than they pay their competition. And when I say more, it's hundreds of dollars more per prescription. And these dollars are what cause increased premiums, increased copays, etc. So when your copay goes up at the pharmacy, it's the PBM driving that, not the pharmacy. The result has been a wave of pharmacy closures. In Pennsylvania alone, they've lost more than 400 pharmacies in 2025. About 250,000 people in Philadelphia now live in a pharmacy desert. That's a neighborhood with no pharmacy within a mile. In rural areas, that distance stretches to 10 miles or more. There are stories of people in the Midwest traveling 40 miles or more in a single direction to get to their nearest pharmacy. When a pharmacy closes, a piece of the community healthcare system disappears. And the trust built over those decades, that trust and relationship goes right with it. Here's the second shift, and this one is more uncomfortable to talk about because it implicates all of us. The accessibility that made pharmacists so trusted, the fact that you can walk up to them anytime, no appointment charge, created an expectation over time that became something else entirely. It became an assumption that the pharmacist's time, knowledge, and emotional capacity were unlimited. And people, regular, ordinary people, not bad people, began to exploit that. Think about what a pharmacy actually absorbs in a single day. Someone comes in furious about their drug price. The pharmacist didn't set that price. They have no control over it. But they are the human being standing between the patient and the system, so they take the anger. Someone's insurance has denied their medication. Again, the pharmacist is going to spend 20 minutes or more on hold with the insurance company, fighting an appeal while the line behind the counter grows. Patient may not even know that this happened because the pharmacist resolved it before they even arrived. But the medication winds up being in a higher tier for a copay, and once again, the pharmacist takes the patient anger. Someone's confused about their dosing schedule and has been taking their medication wrong for months. Pharmacist catches it, corrects it, counsels the patient. Patient doesn't thank the pharmacist. They're angry that they didn't know they were taking their medication wrong. And then someone starts yelling because their prescription isn't ready yet. The fact that we don't charge for our time has devalued us. Every profession, whether it's a plumber, electrician, car mechanic, lawyer, accountant, doctor, etc., charges for their time. We are the only medical profession that has a cash register as our main interface with the patient. And that's turned our stores into the equivalent of a deli where customers constantly abuse and disrespect the workers. Pharmacists are medication experts, but the bottlenecks we have zero to do with our education. We do not set a copay for a patient's medication. We cannot control when or if your doctor will call us with a prescription authorization for you. And we don't control what medications are on manufacturer backorder. We don't write the laws that state how many pills of a narcotic you can get or how soon you can get it. We did not choose your insurance coverage for you. We do not know what medication is covered on your plan without having a prescription first. But we're willing to help you navigate these issues so that you can get the optimal medication to treat your condition. We want to see you healthy. We want to see you succeed, and we want to be a part of that success. But we deserve respect in exchange. We don't deserve public ire when a prescription takes more than 5 minutes to fill. Research has documented patterns of abuse with striking clarity. Nearly half of all pharmacists report experiencing some form of workplace violence. 50% have been subject to verbal abuse. In one survey, 21% of pharmacies reported experiencing verbal abuse from patients on a daily basis. To me, 21% seems pretty low, honestly. I can't tell you how many times I've been called stupid or inept because a doctor didn't call back and respond to our refill requests. And these aren't just words. Documented incidents include strangulation, punching, objects thrown across counters, attacks after closing time, racist and sexist slurs directed at people who have doctoral degrees. All they're doing is trying to help. When I was about 26 years old, I was working in Red Bank at Katz's Pharmacy. Corner of Catherine and Shrewsbury Avenue was the tagline on our labels. When after closing, I was approached by someone with a machete because earlier in the day, I refused to fill their Percocet. Thank goodness it was a time when we all were using the club to lock our cars. So I had a weapon to help me get out of that situation. I jumped in my little Honda Civic and sped away. I called my boss and said, I'm never going back there. Fire me, do whatever. I don't care, but I'm never going back to Red Bank. I follow so many pharmacists on Instagram and TikTok, and I'm amazed at how many take abuse and the videos that they show. It's an epidemic. We're worth more than this. One pharmacy organization noted that because of where pharmacies are located, usually on a street open to anyone with no security checkpoint or waiting room buffer, their staff are more exposed to abuse and threats than their colleagues in other healthcare settings. And the system's response to all of this? It's largely silence. Police response is frequently inadequate. Employer protections are inconsistent. And the culture of the profession, a culture built on service and on absorbing whatever patients need, on being there, doesn't give pharmacists a lot of room to say, this is just too much. In some chains, if a pharmacist verbally steps up and defends themselves, it usually winds up with the patient getting a gift card from corporate and the pharmacist getting a write-up. Way to stand behind your professionals. So pharmacists absorb it day after day. The pharmacists and pharmacy staff take on the anger and mistreatment by the public. I don't know a single pharmacist that went into this profession not having compassion and empathy for others. We all want to help others. We all went to school for 5, 6, 7, 8 or more years to help others to heal. So we continue to absorb. Psychologists have a name for what happens when you do that long enough. It's called compassion fatigue, and it's a precursor to something more serious, which we'll get into in the next episode of the series. But first, I want to take you back to the 1990s, because to understand where pharmacy is today, you have to understand the opioid crisis, not just as a public health disaster, but as a story about how medical health education was corrupted from the inside. And I want to start with something personal. If you went to school in the 1990s, you may have been taught a specific thing about pain management, something that probably felt right at the time, like moral clarity, like the profession was finally getting something right. It went something like this. Allowing a patient to be in pain is unethical, and A patient who's truly in pain, a patient with genuine, legitimate pain, can never become addicted to opioids. That wasn't fringe thinking. That wasn't something your school came up with independently. It was the official consensus of virtually every major medical institution in America. It was in the textbooks. It was in continuing education seminars. It was essentially what medical school, nursing school, pharmacy school taught you if you enrolled in the 1990s. And how did that happen? Well, that's the question. And the answer is genuinely shocking. It starts with a paragraph, one single paragraph. In January 1980, a letter to the editor appeared in the New England Journal of Medicine. It reported that among nearly 12,000 hospitalized patients treated with narcotics, fewer than 1% became addicted to those narcotics. One paragraph. It was observational, wasn't a study, narrow data set, hospital patients only. There was no follow-up, no outpatient data, and that letter was subsequently cited uncritically and unethically in 439 other scientific articles. Researchers, physicians, educators repeated its findings as settled fact, most of them without ever having read the original letter. It became in the scientific literature a kind of citation fossil, referenced endlessly because it had been referenced before. And pharmaceutical companies noticed. In 1995, the American Pain Society proposed that pain be measured as the fifth vital sign, alongside blood pressure, temperature, heart rate, and breaths per minute. The idea was genuinely well-intentioned at its core. Chronic pain was undertreated. There were patients suffering unnecessarily, and medical culture had overcorrected toward withholding opioids even when they were clearly appropriate after surgery, in terminal illness, in severe acute injury. The problem was what happened next. Purdue Pharma, which was preparing to launch OxyContin in 1996, saw the pain movement as a market opportunity. They helped fund a pain management education program organized by the Joint Commission. That's the accreditation body whose standards determine whether hospitals keep their licenses. The Joint Commission published a guide sponsored by Purdue Pharma and the National Pharmaceutical Council that told physicians their concerns about addiction were, quote, inaccurate and exaggerated. It stated that there was no evidence that addiction was a significant issue when opioids were used for pain control. So between 1996 and 2002, Purdue Pharma funded more than 20,000 pain-related educational programs. Their sales representatives were trained to tell physicians that OxyContin's addiction risk was less than 1%. The company produced promotional videos featuring patients whose lives had been transformed by the drug. They trained and incentivized sales force and deployed them to nearly every medical office in the country. By 2001, the Joint Commission, whose accreditation standards governed hospital reimbursement, formally required that pain be assessed and addressed in all hospitalized patients. It's not a suggestion, that's a condition of accreditation. And the Federation of American Medical Boards threatened physicians with investigation and disciplinary action for undertreating pain. Policy was drafted by individuals with financial ties to narcotics manufacturers. Patient satisfaction scores, which were linked to hospital revenue, created another lever. Doctors who prescribed opioids freely got better scores from patients who felt their pain was being taken seriously. The system rewarded aggressive prescribing and punished restraint. Every institutional force pointed in the same direction. Prescribe more. When 10 milligram didn't work, give 20, then 40, then 80. Does anyone remember the 160 milligram OxyContins? It's insanity. Now here's why I want you really here, because this is the part that gets lost in the outrage about Purdue Pharma. The nurses and doctors and pharmacists who prescribed, dispensed, and administered these medications, most of them were not corrupt. They were not operating pill mills for cash. They were doing what they were taught in school. They were doing what the accreditation standards required. They were doing what the continuing education seminars told them was the ethical thing to do. All of our professions demand that we treat the patient, and our hearts demand the same. One of the researchers who helped build the scientific case for liberal opioid prescribing, Dr. Russell Portnoy, whose work was cited throughout the 1990s, later admitted this publicly. He said, "What I was trying to do was create a narrative so that the primary care audience would feel more comfortable about opioids in a way they hadn't before." In essence, this was education to destigmatize, and because the primary goal was to destigmatize, we often left evidence behind. He added, "Clearly, if I had an inkling of what I now know then, I wouldn't have spoken in the way that I spoke." He was describing the scientific consensus of an era, and the healthcare professionals who absorbed that consensus and acted on it were, in a real sense, also victims of it, caught between a system that had been deliberately corrupted and patients who were genuinely suffering. So how did the teaching change? Slowly, then all at once. The overdose deaths started making headlines in the early 2000s. Regional newspapers broke the first stories. By the mid-2000s, national investigations followed. State attorney generals began filing suits. In 2007, Purdue Pharma paid $600 million in fines for making false claims about OxyContin's addiction risk. Eventually, in 2016, the same year that overdose deaths reached their peak, physicians' organizations voted to rescind their support for pain as the fifth vital sign. The Joint Commission revised its standards. The CDC issued new prescribing guidelines, explicitly warning against opioids as first-line treatment for chronic non-cancer pain. And medical education began, slowly, unevenly, but meaningfully, to change. Today, the best pharmacy, medical, and nursing schools teach pain as a complex, multidimensional experience that requires a multimodal response. Physical therapy, cognitive behavioral therapy, interventional procedures, non-opioid medications, and yes, sometimes opioids, but with careful monitoring, clear treatment goals, and an honest conversation about risk. Federal law now requires new prescribers to complete at least 8 hours of training specifically on opioid use disorder before they can prescribe. Some schools are leading the way. For example, UC Davis Medical School now dedicates more than 100 hours of required clinical content specifically to pain management across all 4 years of training. Students there study not just pharmacology, but the social determinants of pain, how childhood trauma can manifest as chronic pain years later, how race and socioeconomic status shape both the experience of pain and the likelihood of having it adequately treated. That's a different kind of education than what a generation of clinicians received in the 1990s. And it matters because the pharmacists, nurses, and physicians who will be practicing in 2040 are sitting in these classrooms right now. There were recently 2 miniseries about the opioid crisis on the streaming platforms, Dope Sick with Michael Keaton and Painkiller with Matthew Broderick. I feel Dope Sick was a little more accurate in its portrayal. In one scene of the movie, the Purdue rep is seen threatening a lawsuit if a pharmacy stopped carrying OxyContin. I remember having reps tell us the same thing as they gave us copay coupons for patients. We questioned reps when we saw patients getting addicted, and we were always met with the fact that the FDA agreed the meds were not addictive except for a small part of the population, and it had to be something else the patients were addicted to. Opioids really were a blemish on physicians and pharmacists. I know pharmacists that were chasing money selling opioid prescriptions. There were so many articles in the news of bad pharmacies getting shut down. But I think opioids are where the public began really mistreating pharmacists. Many of us were refusing opioid scripts. Look, if your doctor is 30 miles north of me and your home address is 30 miles south of me, am I really the first pharmacy you saw and thought, hey, I think I'll go there? No. But when we refused out-of-town addresses or doctors we didn't know, which, by the way, are standards of practice today, we were yelled at, threatened, got bad Google reviews, etc. These were the first patients calling us stupid and cursing at us and throwing things at us. These are the ones that started complaining that pharmacists were not doctors and we should stay in our own lane. Just shut up and fill the prescription. Before it was demanded of us by the DEA and wholesalers, we were doing our own due diligence. We have a legal and ethical responsibility to fill medications. We want to help. We never want to hurt. So If your pharmacist takes a few minutes extra on your script to determine if it's a legitimate reason that you're getting it, be thankful that that pharmacist cares about you. Well, we've covered a lot of ground today. Started with trust, the extraordinary public trust that pharmacies and pharmacists earned over decades, and how it began to erode as the profession was squeezed by corporate forces, as independent pharmacies closed, as the intimate neighborhood relationship that was built by trust was replaced by drive-through windows and performance metrics. We talked about what happens when accessibility becomes exploitation, and when the most available healthcare professionals in any community become the lightning rod for every frustration in a broken healthcare system. And we trace the roots of one of the defining public health catastrophes of the modern era, an opioid crisis built not in the shadows, but in conference rooms and classrooms and continuing education seminars, funded by pharmaceutical manufacturers who knew exactly what they were doing. That's the backdrop. That's the context. But the story isn't over, because the most devastating chapter, the one that the research community is only now fully documenting, is happening right now to the people still standing behind those counters. In the next episode, I'm going to talk about what the profession's crisis is actually costing. The burnout that has become epidemic, the mental health toll that's been invisible until very recently, the suicide data that stopped researchers cold when they first looked at it. And we're going to ask whether American pharmacists face something uniquely worse than their counterparts around the world, and what, if anything, can actually be done. That'll be next time on RX Reflections podcast. Well, before we end today, I need something a little bit fun to counter all the heavy. In each episode, I'm going to share what we're listening on to the radio that keeps us happy at work, and maybe share what book or TV series I'm currently watching. This week, we listened to a lot of Pink Floyd. Animals is my favorite album of theirs. But when we listen to The Wall straight through, I have to stop whatever I'm doing to sing The Trial. Most of us at the pharmacy are over 40, so we love classic rock, but we also take a lot of detours. Recently, we listened to some 80s freestyle because African Bambaataa had just passed away, which then led into TKA. Maria, she had a boyfriend, drug dealer. Great song. We're all over the place with our music, but we always get compliments from the patients. They love what they hear. Currently, I'm watching the newest season of Your Friends and Neighbors. I'm not sure if I like it as much as the first season, but I'm only 2 episodes in, so we'll see. I'm also reading an awesome book by Atiba D'Souza. It's called The Delegation Trap. This is an awesome book. Dr. Lisa Fost from Diversify RX gave this book to all of her attendees at the end of March at her conference. I can't thank her enough. If you're an independent pharmacy owner and you're not a member of Diversify RX, you need to check them out. It will change your life. Anyway, that's it for today. Be sure to check out our next episode where I discuss the pain a lot of pharmacists are going through. It's going to be a heavy episode. A lot of sadness in the world right now for pharmacists. But again, I think we can reclaim our profession, and I look forward to seeing you next time on RX Reflections.